Hello there, and welcome back to our podcast on all things coaching in higher education. My name is Tim Jansa. I'm a certified leadership and organizational development coach and your host for this series. My next guest is Dr. Heath Jolliff, who's a certified executive coach with Physician Coaching Solution and a board certified physician. I asked him to share some much needed insights into a topic we hardly ever hear about in the coaching space, which is the unique challenges of coaching for university medical centers. And who better to help us understand this world than a board certified physician and coach? So let's get started.
Hi, Tim. How are you? Thanks for having me today.
Absolutely, it's my pleasure. It's great to have you on, Heath. So I did a little research on ChatGPT, and it looks like there are more than 200 university medical schools in North America. And according to ChatGPT, it's 196 in the US and 17 in Canada, to be precise. So why do we hear so little about them, especially in the coaching context?
Tim, you're right. There's a really vast ecosystem of academic medical centers and medical schools, and they really tend to fly under the radar, when it comes to mainstream conversations about executive coaching or leadership coaching. And there's a few key reasons for that. Um, I would say first is medicine has a really strong culture of self-reliance. Academic physicians and leaders are trained to be very highly self-sufficient,
Hmm.
and coaching can be perceived incorrectly as remedial rather than developmental. And this stigma is slowly shifting, but it's still present.
That's a really interesting point you're bringing up here with the culture of self-reliance, because again, as leaders, we operate not in a vacuum, but within a system. And so when you have somebody who's trained to be just to be the master of their own world, that can be really tricky, I guess, with in any kind of leadership aspects. Um, so I'm wondering, so how do you actually work with clients to maybe embrace a little more systemic view and maybe accept or appreciate the interdependence and interreliance with other people in their field as part of their developing their leadership skills when self-reliance is really their go-to MO?
Yeah. It helps to start with helping clients identify where their self-reliance serves them and where it silently limits them. And we tend to explore the unintended costs of doing everything alone, like burnout, decision fatigue, lack of innovation. And from there, I tend to introduce the idea of interdependence is not a weakness, but a leadership strength, especially in complex or complex systems like academic medicine. And overall, clients begin to shift from I have to do this to who do I need with me to do this well.
I love the way you phrased this, where you said that interreliance really is a strength, and bringing awareness to the drawbacks of self-reliance. And I'm sure, I mean, there are times when you, especially as a physician, when you just have to rely on your training and just save somebody's life, right? I mean, the same is true also when you're working, I'm sure, with new physicians and in these medical centers, these medical schools. Um, but what you're bringing up is so important for coaching in general, and that's creating awareness. So the client has to do the work. We're there to guide them. But one of the biggest doors we can crack open for them is that greater sense of awareness of where things might be an asset and where they might be a liability. And so I'm really glad you brought that up. Um, as far as coaching being established in medical schools, you mentioned earlier that it's not very well established. What is there something that has been in place of that? Is coaching something that is replacing some other development tool? Is it augmenting what already exists, or is it just an approach that's relatively novel in the field?
Yeah, coaching is still relatively new in academic medicine. While coaching is gaining traction in corporate and even healthcare systems, academic medicine has been a bit slower to adopt the standards for leadership development and things like that. I often see it reserved for crisis moments or elite leadership tracks rather than being offered more broadly. So it's not really replacing things. I would say it's more augmenting. It's traditionally development in this space really relied on mentorship and
Mm,
kind of hierarchical guidance. And coaching introduces a whole different dynamic, as you know. It's non-directive, it's confidential, it's growth focused, and we can feel novel and refreshing. This can feel novel and refreshing for academic leaders. And I would say in the past decade, coaching has kind of gained traction as leadership demands have intensified and unfortunately burnout has increased. And many institutions now see it as a vital component to mentoring, especially those navigating more complex roles or even transitions.
I just had a conversation about mentoring, actually a couple of conversations in one day. And one thing that I thought I became aware of is that mentoring really does have its limits, especially when the mentor is a very seasoned, established leader and the mentee is a young, newer generation, uh, in this case, physician. Because mentoring is very much based on the idea that the environment, that the advice that the mentor can provide is still applicable and relevant. And since so many things have changed, I can imagine, especially since COVID-19 and the trauma and the experience that especially medical professionals have had, maybe some of these experiences that the mentors can share don't necessarily apply anymore. Is that something that you see as well?
Yeah, academic medical centers are, steeped in hierarchy and tradition,
Mm,
and it often makes them resistant to new models of professional development. And like you
mm.
said, mentorship has always been the dominant paradigm. And so coaching sometimes, or we struggle to find its footing alongside that. And I think that hierarchy kind of shapes everything. And senior leaders may be offered coaching as a perk or for performance support, while a lot of times junior leaders kind of hesitate to seek it out due to fear of appearing weak, or this is something that only people that have problems with get. And as a coach, I try to work more carefully to create psychological safety while also acknowledging the real political dynamics that they're navigating. And my approach is kind of honestly grounded in humility and context awareness and really helping clients find influence within the system and not just over the system.
And I can see how that is extremely difficult sometimes for clients, especially junior leaders in a strongly hierarchical system. And you and I have talked about this, where it seems to me that medical centers kind of marry the challenges of both a university structure, but then also a structure of a hospital, where hierarchy is also so important because I mean the stakes, quite frankly, are so much higher. So how does this hierarchy and the tradition that comes along with it, how does that affect the coaching dynamics and especially like coachability of clients? Uh, you mentioned also who gets coaching, why, and so how do you approach this in your work? How do you work around these constraints that hierarchy often impose on us?
Yeah, it's a great question. It is reaching out initially and kind of making contact with those decision makers. And a lot of times I find that someone in that group has had coaching before and trying to find out why did you seek coaching or why was coaching offered to you? And do you think this would be something good for your team? And really putting it into that positive light as an investment, as a leadership tool, a developmental tool, and to take people to that next level because, medicine is a business now and there is a lot of competition. I've worked with systems who, they have coaching in their system and their competitor does not. And once it gets, people find out about those things, it's a great thing to offer to people, just like in the corporate world. I see coaching being offered as part of benefit packages now, and I'd love to see that throughout healthcare.
It's interesting that you bring this up because I have another client at a big research university, and it's the same thing. She actually negotiated coaching into her hire offer because she had experienced coaching before and really values it. And she's been an amazing client. Uh, but also, what you mentioned, I think, is the calling for us as coaches. Just looking at the ICF ethical guidelines is also for us to promote coaching as a meaningful development tool. And what you're doing, I think, is very important work there because you are showing more people the power of coaching, and then you're inviting others into that space. So I think it's you're doing some amazing work there, I must say. Um, you mentioned medicine as a business, and you're absolutely right. And I've said higher education in general is a business, even though it really shouldn't be. So when we talk about business, we're always getting to the point of, what's the financial bottom line of all that? And with all the changes that are coming down the pipeline, resource allocation and budget is such a huge aspect of what people are dealing with in this world. Of course, we as coaches, because we rely on resources being available, uh, it's really tough sometimes to land that coaching gig. So, how do you formulate your value proposition? How do you convince leaders at those schools to make funding available for coaching? Because I mean, it's not necessarily a very cheap solution.
Yeah, Tim, you're right. Medical schools often operate under very tight budgets, especially if they're a public institution, and coaching may not be prioritized unless there's a clear ROI, return on investment, or it's funded through external grants or leadership programs. So my value proposition for these centers is on retention, performance, well-being, and I find that these three metrics are things that academic leaders care about. Highlight how to help prevent burnout, reduce the costs of turnover. It's estimated now that to replace a physician in a medical system is $500,000 to $1 million or more. So how do we prevent that? How to offer support more effectively, obviously emotional intelligence, and sharing real examples of how coaching can help leaders navigate that high stakes decisions, build a stronger team culture, and also position coaching as a proactive investment again, and not a remedial tool. Really make that as part of succession planning and leadership transitions. And I think last, pardon me, kind of aligning coaching outcomes with institutional goals like faculty engagement or strategic change.
How receptive are the people you're talking to about these things? Because I can see how somebody who's very much, say, business oriented, these are very people centered arguments. A lot of extent, even though when you're saying, it costs more than $500,000 to replace a physician, I mean, that definitely raised my eyebrows, and I'm sure it raises other people's eyebrows too. But how receptive have people been to these arguments?
I think it's getting better because initially, just like I have a friend of mine who's in Congress, and he said, if you can, save things, out of a budget, it's kind of looked upon as like, yeah, that's great, but is that going to really happen? And then where's that money going to get funneled to? And so a
Mhm.
lot of times when you're talking about saving money, I think institutions are becoming more receptive to that because budgets are there. But I think what's really helping people is that physicians at these centers have a choice of moving elsewhere.
Mm.
And hospitals really want to prevent that if they can. It's, if you have somebody who's a high functioning leader, someone who's publishing a lot of research, you want to retain those people. You don't want them leaving and going somewhere else. So I think that's been really helpful also.
Oh, absolutely. I mean, the same is true in higher ed space in general. I mean, you have, especially on the faculty side, you have some experts there who can really contribute to the image of the institution, and that's something, of course, that senior leaders, executive leaders, care very much about. So we definitely want to keep these people. Um, Heath, I wanted to kind of shift our conversation maybe slightly. Um, in other venues, we've talked about the challenges of higher ed, and of course, I published this intro video with Primer on the challenges of coaching in higher ed. But what would you say are some challenges that are very specific to coaching in medical centers? You've already addressed things like burnout, for example, and retention. What other things are there that you're seeing in your work?
Yeah, I would say, and you kind of alluded to this before, I think there are kind of three big challenges that come up in these institutions. And each institution obviously has its own culture, but I find these to be remarkably consistent patterns. And I would say the first is that academic requirements that are done versus patient care. And it's probably the most persistent tension in academic medicine. Physicians are expected to be outstanding clinicians and be productive researchers or educators. And that dual expectation sometimes feels impossible, especially when clinical care takes up a lot of time and energy. And an example is a faculty member might be judged for, how much money they're bringing in, their RVUs, and may also be expected to publish and teach. And coaching can help leaders really clarify their priorities, set boundaries, advocate for structure to support both these missions more realistically. Um, and I think the second thing I would say is that I find a lot, and you and I had talked about this previously, is role conflict and ambiguity. Um, we get a lot of titles like vice chair, program director, associate dean, and they sound clear, but the actual responsibilities are often really poorly defined or ever evolving. And it's common for leaders to be handed a role without a roadmap or the authority to match their accountability. And coaching kind of helps that leader to find their own lane, align their expectations, navigate upward, laterally, downward, and while holding on to their own sense of identity and purpose. And I think the last thing, which affects so many of us, is just time management. And time in academic medicine isn't just scarce, it's really fragmented. Leaders are pulled into, I'm teaching now, I'm doing research, I'm doing clinical care, I'm doing administration, and countless meetings. And this issue is rarely just about productivity. It's often about permission, giving themselves the right to say no, to delegate, to invest time in what matters most. And coaches can really help clients move from the reactive to the intentional and design their calendars to reflect their values and their strategic goals.
You just touched on something that I've been meaning to ask you about anyway. It's like when I look at all these conflicting priorities and pressures, I can only imagine how much stress and anxiety this actually creates. And you mentioned burnout earlier. It's one of the symptoms of this. Um, how do you work with clients to build maybe this capacity for greater self-compassion, to giving them the tools and the strength to take time out? Because I can imagine that this is really a big challenge because people are so used to always being on the go.
Yeah, absolutely. I have a friend that's been coaching physicians for 2 decades, and she has a quote, and it's basically, we in healthcare, we often forget to take care of ourselves. But if we're not taking care of ourselves, we can't take care of other people. But we try. And that's where I see clients getting really burned out is, I talked to a client just last week and I said, when's the last time you went on vacation? And he paused for a while because he thought, maybe three, I don't know, maybe 4 years ago, could have been five. And it's
Wow.
funny because I have clients in other healthcare industries that aren't directly in patient care, and they take vacation every year and just get away. And we tend to forget that there is this life outside of medicine and forget to take care of ourselves, because a lot of clients bring work home with them all the time, and it just becomes such a natural thing for them. They forget to take that break. And when we start talking about burnout, we really have to break down, what is the job? What is your life? How do you integrate those things better? And what's the most important thing to you? Because, sadly, I've seen people that come to me later in their careers and, they've had a very successful career, looks great on paper, and then they tell you, yeah, my spouse divorced me a couple years ago. I don't really have a lot of friends outside of my department or outside the hospital. And now that I'm starting to think about retiring, I'm faced with what do I do now type of thing. So we really have to make sure we're taking care of ourselves and finding that time and that permission to do so.
Yeah, I always talk about leadership capacity because we can't, if we don't have the capacity to lead, then nobody wins.
Yeah,
Right? And I mean, this
absolutely.
is this is one of those things we're taking time out for ourselves. I was wondering, this is probably a kind of a rhetorical question, but I assume you've seen some big differences between the clients who actually do take time out and do take care of themselves versus those who don't.
Oh, absolutely. I've had clients that come with everywhere from, I'm starting to feel a little twinge of burnout to people that come to you and they're so burned out they don't even realize it. They'll come to you and say, I just don't know what's wrong. I don't know if I'm depressed. I don't know if, just all these things. And once you can get people to identify that, it's kind of like patients. A patient will come in with all these symptoms but not know what's wrong. And once you can help them with a diagnosis, and I hate to say it, but label something, sometimes people feel a lot better because it's like, oh, now I know what's wrong or what my challenge is. What are the steps now to get to where I'd like to be? And really identifying with clients, where you are, where do you really want to be, especially 5 years, 10 years from now, or even farther than that. And I find a lot of people stumble over that question because they just haven't thought about it. They're like, well, I just kind of go to work every day. And you say, where do you want to be a year from now? And I get a lot of clients that say, I don't know, I just haven't thought about it. And it's really giving them that permission to pause, to reflect, and to help figure out that next step.
I'm so glad you brought up labeling. And for those who are new to the coaching field, people sometimes wonder, like, why are we asking these really high level questions? And I think the reason is we want our clients to come up with the labels because the labels have to work for them. They have to come from the inside and be meaningful to them rather than saying, well, you are suffering from XYZ or you need to be aware of XYZ. That's the advice trap we sometimes fall into, especially as less experienced coaches. So allowing our clients to come up with the labels to develop this awareness of what uh, may be wrong, areas of development, so forth. I think that's a super powerful tool. Heath, I wanted to ask you something that there's a reason for this, obviously. The reason is in higher education in general, and let's say in academia, a lot of the leaders who come from the academic side of the house, when they start enlarge their first leadership position, they generally don't have a whole lot of leadership training. And I'm wondering, what is this like when you look at leaders in the medical center field who are also physicians, but then of course also have an academic component to it? What are you seeing there, and where perhaps is there some more room for improvement in terms of leadership training?
Oh, that's a great question. When I was going through my coaching training, we had several people in the group. I think there were like 50 of us. And it was great because there were people that worked for big tech companies, big pharma, all these things kind of outside of traditional healthcare. And it was very interesting. A couple of them asked me, they said, so, how much leadership training do you get in medical school? And the answer is usually none.
Mm,
You kind of, if you're interested in leadership, and I tell all physicians, you're always a leader. You may not kind of identify that way, but you're always a leader. People are looking up to you, your patients, your staff, those type of things, and you're part of a team. But we tend to find somebody who is that ideal leader that we see in someone we work with, and then we kind of model that behavior. Or if we're lucky enough, we ask them to be our mentor and to help us along those lines. I've had physicians that go into leadership and say, well, I have to go get an MBA or I have to go get a master's in healthcare or something like that to be a better leader. And sometimes that may be true. But other times it's just looking inward again and finding out what skills do you have. And sometimes we use assessments and other tools to figure that out. What do you need for this next role or your current role that you're in? And how can we optimize those things that you currently have? And then what things do you need to get more training in? And I think it's just identifying that because clients will come to me and say, I'm in a leadership role and I don't even know where to begin. And it is a big thing. So it's like, well, let's break that down into little bite-sized chunks,
mm,
so we can figure out where you need to go next.
yeah. There's one thing that I've been dying to ask you about, and that is a
Okay.
very simple three-letter word, and that is the word ego. I mean, when most people think about physicians, of course, they think about the incredible skill and years of training to get them to that point. But I think we all have probably met some physicians too that have a little bit of ego, or maybe a lot of it. So I'm wondering, how do you break through that? Because to some extent, you kind of have to when you're working with them in the coaching space and making them a little more aware and willing to change and address some of their needs that they may not know they even had.
That's a great question. You know, sometimes clients get referred because of that ego problem, or
Mm.
we have a term in healthcare that I don't like, but it's the disruptive physician. And I often say, well, why do I never hear that term applied to anybody else? Because anybody can be disruptive. And it can be ego, it can be cynicism, or things associated with burnout. Some people just have some personality quirks that make them difficult to work with. And so if I have a client who ego is an issue, first getting them to understand that, and really working on what is your challenge, and why do you think that is, and or why were you referred to coaching, or those type of things. And once you kind of break it down, a lot of clients, they'll figure it out, and then the next step is, a lot of times, I didn't realize I had this. We get that with like a 360 evaluation, for instance. What do our colleagues and team members think, and that type of thing. And then how can we break that down again? Because none of us are perfect. We all have issues, but ego can really stand in the way. And I've seen, I've seen clients that have not been able to break through that. And the downside of that is the question I often ask is, what do you think is going to happen if you don't make the change? Because I've seen physicians get fired from a position, and it's because of their attitudes and their ego and things like that.
That's a super powerful question, and thank you for sharing that advice because again in academia we're having this same discussion to some extent, but again that's why I wanted to ask because in medical centers I can see that it might even be a little more prevalent. But this brings us back really to the question of awareness, right? How do we as coaches help our clients create this awareness and then lead them from that platform of awareness to like, okay, what are we going to do with this? Where are we going to take this to make you be and do better? Is there any other advice that you would give to any coach who is perhaps already established, but maybe even entering the space or might have the opportunity to work with a client at a medical school?
Yeah, I tell people, I say academic medicine coaching there is deeply rewarding, but it's not for the faint of heart. So my advice to coaches is, if you're going to step into this space, first do your homework. Understand the culture. Academic medical centers are their own ecosystems. Learning the language, the power structure, the realities that your clients are facing. This isn't an area where you can fake fluency. And then, lead with humility and not authority. You're going to be coaching incredibly smart, high achieving people, many who have been used to being the expert in the room. So don't try to match their expertise. Instead, bring curiosity and presence, thoughtful challenge. And that's where trust really builds. Um, I would say the next thing is, hold space for both the personal and the systemic. Your clients are going to be wrestling with internal doubts, like we've talked about, but that external complexity. So you have to be able to zoom in on the mindset and the emotion, but also zoom out to the strategy and the systems thinking. And that range is really going to be, your superpower. And I would say the other thing, which is something that we have to teach physicians, but also coaches, is be patient. Change is slow. These institutions don't move quickly. Progress may be incremental. Sometimes the biggest win is helping someone stay aligned with their values in a system that's not really built for them. So people have to, stay grounded in their center. And the other thing with coaches is you've got to bring compassion and also courage, because you're not just a sounding board. You're a mirror. You're a partner. Sometimes you're a quiet disruptor. So don't be afraid to name the hard things or challenge unhelpful narratives, and just do what you do with heart. And that's going to help a lot.
Words to live and coach by, Heath. I couldn't have wrapped this up any more beautifully than you just did. Thank you so very much for sharing your expertise and your experience. This has been absolutely fantastic. And I really appreciate your taking the time to speak with me today.
Great, Tim. It's been a pleasure to be with you.
Absolutely, absolutely. And for all of you watching this, thank you so much for your time. If you enjoyed today's episode, please click the like button and subscribe to this channel. Your support really means the world to us. You can also find more information about our guest, about this episode, and about the topic at our companion website at higheredcoaching.us and leadershipimagined.com/podcast. Thank you so much, and see you next time.